circulation will subsequently cause prostaglandins accumulation. And this will cause vasodilatation. It's a
I'm trying to know.
peripheral resistance and BP. AC inhibitors. We have several recommendations, several guidelines when it after myocardial infarction,
Let me add your
hypertension, stroke, and what have you.
You didn't try joining me.
The so-called pleiotropic benefits. Can somebody tell us some of the pleiotropic benefits?
I'm still recording, so.
Of AC inhibitors.
Exactly.
The
Wi-Fi.
they do, they can reduce.
I only Windows 10.
What are some of the
It's Windows 10. Windows 10 has to come.
of AC inhibitors?
Yeah.
They share this in common with the ARBs and even statins.
Private.
Statins do share similar benefits. ARBs share these benefits as ACs. Anybody pleiotropic benefit?
Yeah, renal protective.
Yeah, renal protective is there. What else?
Doc, I think they have antioxidant effects.
Antioxidant effects.
Anti-inflammatory.
Anti-inflammatory, anti-proliferative. They maintain endothelial function. So you see, and if you are to look at the pathophysiology of all these,
no, I'm not added to it.
You will see inflammation, proliferations, and all those things. So if a drug can do this, then of course it will be highly favored when it comes to those conditions. This is a very popular agent like Sunopril that we use a lot. All the prils are examples of ACE inhibitors. Side effects, persistent dry cough, possibly due to the accumulation of bradykinin. Because the ACE doesn't only cleave angiotensin 1 to angiotensin 2. This is a peptide, this is another peptide, though this is longer than this. So the ACE will cleave a certain portion of the angiotensin 1. It becomes shorter, then we call it angiotensin 2. Physiologically active. Bradykinins are also peptides, and they serve as substrates to the ACE inhibitor. So if the ACE to the ACE, so if the ACE is around, it doesn't only break down angiotensin 1.
No, you didn't know that.
By breaking down bradykinin,
it reduces
the risk of bradykinin causing irritation within the airways and causing persistent dry cough. Once you block the enzyme, angiotensin 2 remains because you are not angiotensin 1 remains because you are not converting angiotensin 1 to 2. Likewise, bradykinins will also stay because the enzyme is not available, it has been arrested. So you don't break it down. This will accumulate, and one of the problems is persistent dry cough. If that happens, then you may have to switch to the ARBs, which relatively would not cause the persistent dry cough. You are causing hyperkalemia. Can somebody explain why hyperkalemia occurs here with ACE inhibitors? Focusing on the RAS.
What you do? I'm trying.
ACE inhibitors induce hyperkalemia. Possible mechanism. Evelyn.
Okay.
Evelyn, can you
let me make it public.
Possibilities?
Yeah.
ACE inhibitors induce hyperkalemia.
Today, let's make it when after the live stream, then
possible
get it to
mechanism involved.
So try again.
Yeah, are you around? Attakorah, I'm calling you because I have a friend called Attakorah. Edem Attakorah. So Attakorah, Attakorah, can you please explain how hyperkalemia can occur with ACIs? Attakorah, are you there? Okay, can somebody take it?
Do you
We
hear
don't want to
the
waste
sound?
much time. We
Or
still
no sound?
have some few slides to go.
The
ACE-induced
sound never.
hyperkalemia. Same goes with ARBs. Class captain, since nobody is talking, please, can you help us? ACE-induced hyperkalemia. Oh, this one you know. It's the same RAS input. Hello? Please, can you hear me? Class, can you hear me? Hello?
Hi.
Yes, sir. Hi, Doc.
Uh-huh. Can somebody just explain? I know you know, but you don't want to talk. This is very simple. ACE-induced hyperkalemia.
Hello.
Yeah, hello?
Yeah, so the ACEs are going to prevent progression of hypertension or hypertension. So they are
Still on that.
interfering with
Your line is
the
not clear. It's not clear. I think it's the distance from your mouth to the speaker. Hello?
hello.
It's better now.
Okay, I was saying that the ACEs interfere with the RAS, so then there will be no production of aldosterone, and aldosterone is responsible for sodium and water retention. So in a normal sequence where there will be sodium and water retention, there will be excretion of potassium, but in this case, it will be the reverse. So the sodium will be lost and there will be high levels of potassium.
Perfect. Thank you very much. So that is what is going
Is
to
it
happen.
hypertension?
As
Okay,
it
they will
said,
block.
normally when you
Okay,
have
okay.
aldosterone
The loop
being
diuretics that
released
will
from
cause
the RAS system,
hypokalemia.
you have sodium water going into the body and potassium leaving. Now that you have blocked the ACE with the ACE inhibitors, you are not going to release aldosterone, which means potassium stays in the body, sodium and water stays in the lumen, and they come out. Hence, hyperkalemia. You can also get this reaction angioedema, and this is very common in the black population as compared to the white, where you have swollen lips and tongue, and you can react. So it can also happen. Contraindications key in pregnancy. So ACEIs are not indicated when it comes to pregnancy. Why? Because they can cause fetotoxicity. They can cause skull defects. The skull of the fetus can be defective. It can also reduce the volume of the amniotic fluid. So they term it as oligohydramnios. Oligohydramnios. So skull defects, oligohydramnios, and even loss of BP and renal control of the fetus. So because of this, ACE inhibitors are not recommended in pregnancy. When it comes to unilateral renal artery stenosis, ACE inhibitors can be used. You have two renal arteries. If only one is constricted, but when two or the two are constricted, you cannot use them. I want you to take this as an assignment. Next week, I will ask you before we start the class. Why is it that ACE inhibitors are contraindicated in situations where both renal arteries are constricted, but they can be used when only one is constricted? So they are contraindicated in bilateral renal artery stenosis. Constriction of both renal arteries, you don't have to use ACE inhibitors. But when only one is constricted, you may use. So ACEIs, their mechanism and the end result is almost similar to that of ARBs. So ARBs do share common characteristics, benefits, and side effects with ACEIs. Just that their mechanism is different, and there could be some slight differences in some of their side effects or their responses. So the ARBs would not block the the production of angiotensin 2, but would rather allow the angiotensin 2 to be produced. But its receptor that is going to utilize to exert
I'm
its
using my data
effects,
to stream.
ARBs will make sure that the
I can't find
receptors
my
are
stuff.
blocked. So which means that you are going to have the enzyme being free to convert
This one said
angiotensin 1 to 2.
this
Remember,
one.
this
So
same
I'll
enzyme
use
we
their
said
own to buy this one.
bradykinases are substrate for the enzyme. So with ARBs, the enzyme is available to break down both angiotensin 1 and bradykinases and other peptides, of course. Meaning that by using ARBs, bradykinases concentration will go down because the enzyme is now available to act. So we can predict that if the dry persistent cough is happening because in the case of ACE highs, bradykinases are high. In ARBs, bradykinin concentrations will be low because the enzyme is free and available to break the bradykinases down. So it is likely that the ARBs, you wouldn't have much problem when it comes to the dry persistent cough because it happens when bradykinin concentrations is high. And this is when you arrest the enzyme with ACIs. When you are not arresting the enzyme and the enzyme is free to break down bradykinases, the dry persistent cough will not be a problem. So that is why in most cases, when patients are initiated on ACIs and then they have this problem of dry persistent cough, the clinicians may switch to an ARB because they wouldn't cause normally problems with the dry persistent cough. Here again, because they are also blocking the final effect of angiotensin 2, as I said, they also have similar benefits just as ACI. So heart failure and the rest, ARBs are also indicated. Examples include losartan, the sartans. All of them are ARBs. They share the pleiotropic benefits. They share common side effects like hyperkalemia and pregnancy contraindications with ACIs. Note that losartan, this that I'm going to say is not a class effect, but losartan has an additional losartan has an additional uricosuric effect. What do I mean by uricosuric effect? It can help increase the excretion of uric acid, and therefore subjects who do have hyperuricemia and therefore are at increased risk of gouty arthritis. Losartan can help decrease the levels of uric acid. So that is an additional benefit that losartan. I said this is not a class effect. It's not common thing that all the drugs in the group will do, but losartan can give you additional uricosuric effect. So losartan, if you want to reduce uric acid levels and the person is having hypertension, that would be a very good candidate for that. Any question? Else we quickly move to the CCDs. Okay, so the calcium channel blockers, all that they do in terms of hypertension, we are talking about hypertension, is to act on the calcium channels within the vascular smooth muscles. The calcium channel, if it's open, calcium will enter and the smooth muscles will contract. When they contract, this will cause vasoconstriction, and that will increase total peripheral resistance, increasing mean arterial pressure. In hypertension, we hate this. So we are going to block these calcium channels on the vascular smooth muscles. Calcium will not enter, there will be no vascular contractility, then the blood vessel will relax. If the blood vessel relaxes, that is vasodilatation. This increases the radius or the diameter of the vessel, resistance decreases, our mean arterial pressure decreases. Generally, in terms of chemical, we have those that belongs to the terpenes, and the phenylalkylamines. The dihydropyridine groups, we know them, the dipins. So phenoldipen, these belongs to the dihydropyridine groups. And preferably, they act principally on the blood vessels. That if in hypertension we are focusing on the blood vessels, pyridines, they act preferably on the blood vessels, then they will be, when it comes to our topic, insulins do have almost equal levels of both blood vessel effect and cardiac muscles effect. And for that matter, we wouldn't want to use them in hypertension, but rather in situations where we want to block calcium channels on the heart, especially on the nodes, SA node, AV node. So which situation are you thinking about? Arrhythmias. So it's in arrhythmias that normally the phenylalkylamines and the benzodiazepines are used. Dihydropyridines, so in hypertension, that is what we are focusing on. They are very good and they are backed by several trials, including the accomplished trial. Remember, we said when we combined the ACE and the thiazides, it was very good. But later on, it was seen that an ACE and the calcium channel blockers are even better. So the accomplished trial backs the use of CCBs a lot. They don't cause much problems with the exception of headache, peripheral edema, flashing, palpitations. These are counter-regulatory responses. Other than that, they don't cause much problem. They have neutral effect on glucose. So you see a lot of hypertensive patients who come with diabetes. They don't cause a lot. You remember we just mentioned hyperglycemia with thiazides, and somebody was so concerned about then their effect when it comes to glucose control. Beta blockers will also interfere with glucose. Unlike these agents, CCPs, they are neutral. They don't cause a lot of problems. And DMs comes with a lot of hypertension. So that is that. One member of this group, nimodipine, will preferably act on the blood vessels within the brain. So cerebrovascular system, that is where they act. And therefore, it is preferred or favored when it comes to subarachnoid aneurysm. So nimodipine is indicated in subarachnoid aneurysm. Can somebody tell us the dosage regimen?
60 milligrams.
Nimodipine in adults
60
for
milligrams.
subarachnoid aneurysm.
I think 4 hours or 6 hours.
It's all being to medicine. Nimodipine.
6 hours.
Dihydropyridine, nimodipine alone will not be used because of hypertension, but rather for the prevention of subarachnoid aneurysm. This, if it bursts, it will give you hemorrhagic stroke. So, can somebody tell us the dose, nimodipine?
I think it's 60 mg 4 times a day, but I'm not sure. I'm not sure.
From every 4 hours.
Uh-huh.
60 milligram 4 hours for 21 days.
For 21 days.
Yeah.
So that, yeah. So remember, this is the way they ask your questions. They know that you guys are aware that dihydropyridines, all of them are indicated in hypertension. So they will slot in nimodipine, and then all the others are there. Which one are you not going to use? So pick the odd one out when it comes to hypertension. So you see in the philodipine, amlodipine, felodipine, then nimodipine is there. Then you should realize that because of its preference when it comes to cerebrovascular system, it is rather indicated when it comes to such problems, but not hypertension proper. All right. So note the side effects. Peripheral edema, ankle swelling is popular because of the vasodilation that happens that reduces BP drastically, flashing, palpitation, tachycardia, and of course, once you have vasodilation, you are having a pooling of blood in the periphery. This reduces the amount of blood that goes into the brain. and that can cause dizziness. If you are not lucky, you can even faint. First dose syncope can occur when the peripheral vasodilatation keeps blood within the periphery. You get reduced blood supply to the brain, and that can cause dizziness, or in the worst case scenario, fainting. All right, so this is trying to show the classes. So calcium channel blockers, you have the dihydropyridines and the non-dihydropyridines. Phenylalkylamine, example, verapamil, benzodiazepine, diltiazem. These are favored when it comes to arrhythmias because they have greater response when it comes to the calcium channels on the heart, and therefore they are indicated in arrhythmias. For the dihydropyridines, we have generations based on when these drugs were discovered. So in the Philippines, discovered first, second generation, estradipine, nicardipine, felodipine. Then third generation, amlodipine. The problem with nifedipine is that it has a short half-life, 2 to 3 hours. The drug is gone. You are way below the half-life, and therefore it is not giving us the conventional tablets for hypertension. If you do that, then you are always going to do repetitions. So the frequency will be high, which will not help.
When I went
The
to
BP will not
16 weeks in the hospital,
fluctuating
their first
because your patient will not comply. And therefore, to solve this, the drug is presented
they
as
start with
a
a loop
modified
that
release
the
preparation,
tie that
an
then
extended
they add
release
nifedipine.
agent. So hardly would you see
So that was the first place I saw
nifedipine being
nifedipine.
used
Like you were
as
using
plain
it all the
tablets,
time.
conventional tablets for
Hardly use
hypertension.
amlodipine.
Hardly would you even find some on the market. We used to have the sublingual one. That's those days were being used for hypertensive emergencies, crisis. That was 10 milligram collapsible capsules that they will put under the tongue. Some people will even prick it to increase the release. That one used to cause a lot of drastic fall in BP, worsening the damages that we fear that the high BP will cause. And therefore, that drug has also been removed from the market. But I learned some clinics still do have sublingual nifedipine, and they are using it for hypertensive emergencies, and that is dangerous. Because once you release the whole 10 milligram into the bloodstream, it causes drastic fall in BP. You are causing hypoperfusion. Hypoperfusion to vital organs, kidneys, brain, your eye, your heart could be catastrophic, and therefore this is not allowed. You better use injectables and titrate and get the desired BP that you want. You see, amlodipine here, third generation, has a very long duration of action, and therefore can be taken just once a day, and you are good to go. Nifedipine, even the sustained release product, at times you have to give it BD. Technically, the sustained release product is supposed to work for 24 hours, but in some situations, you give it and it still fluctuates, and therefore you see clinicians giving it on BD phases. So 30 milligram morning, 30 milligram evening, or 60 morning, 30 in the evening time. But amlodipine intrinsically, it has a longer duration of action. So whether 5 milligram or 10 milligram, you don't need to modify this drug. You take it once a day, and it's possible that it can cover you for a whole day. Between the two, this one has almost insignificant effect on the heart. Nifedipine is said to have approximately about 1% effect on the heart. So between these two, these two are the most common, nifedipine and amlodipine. That's why I'm talking about the two. In Ghana, if it's not nifedipine, then it's amlodipine, and vice versa. So that's why I'm focusing on the two. So this one, on the heart, it has almost negligible effect. This one, on the heart, it may give you some 1% effect. So we know that nowadays, calcium channel blockers are not like no in situations like heart failure. Previously, we were saying that, oh, once the heart is failing, why do you give an agent to block calcium? Then you fill the heart, you worsen it. But nowadays, if the ejection fraction is preserved, you can use calcium channel blockers in heart failure with hypertension. And therefore, if you are going to do, then it is wise. It is wise for you to use an agent that has negligible effect on the heart as compared to someone who has some, though not that strong, but some effect. So in heart failure with preserved ejection fraction that is allowed for you to use calcium channel blockers, preferably it is better to use amlodipine with negligible cardiac effect as compared to nifedipine. Any question? Any question?
I have a question. In relation to, I didn't get the you're saying that because of the action of the nifedipine, like within 3 hours to start acting, it's not preferable to give it for it's not preferable to give the plain nifedipine. We should rather do like the extended release and then the slow release. Please correct me if I'm wrong.
Yes.
Uh-huh.
Why? Because you are managing hypertension. And you see, if it's a chronic condition that the person is going to take all through lifelong. So why would you give a drug that will work for just 2 hours and you have to repeat? So within a day, you are going to do like, let's say even if it is 4 hours or 6 hours, you are going to do like four times all through your life. So every 6 hours or every 3 hours or every 4 hours, you are going to swallow the drug. Obviously, adherence will be a problem. You get it?
Yes, please. I'm asking because of the nifedipine protocol, like in the management of say preeclampsia on the ward, because I've seen them give nifedipine sublingual plain for like with the protocol where you give 10 milligram. Then after 20 minutes, if the BP is not controlled, you do another 10 milligram for about 5 cycles. Then you probably switch to hydralazine. So I wanted to confirm if it was accurate because you mentioned that some facilities do the plain nifedipine, but it's not like ideal. But I'm not too sure if that's what I heard. So I wanted to just clarify.
So what are we talking about here? Hypertension. Do you
Yes.
get it?
Yes, please.
We're talking about hypertension. So in hypertension, especially during the crisis, that is when they use the sublingual one. The drug is not indicated anymore. It's not favored. Why? Because during the crisis, you shouldn't drop the BP too drastically. You do that, you cause hypoperfusion and you cause more damage. And here is the case when you release all the 10 milligram at once from the sublingual one, it is likely going to cause, and it was causing that. People were suffering from blindness, ischemic stroke, acute kidney failure, blindness, heart problems, all because of excessive amount of the nifedipine that has been released from the sublingual 10 milligram. So if you have to look at even the current STG, though 7 years ago, you see that it is not recommended as part of the drugs that you use in the management of hypertensive crisis because of these problems. When it comes to chronic management too, the problem is if you use plain nifedipine tablets, the half-life is about 2-3 hours, meaning you are going to do frequent administration. Adherence will be a problem. And therefore, the plain or the conventional nifedipine tablets, you can't even find them on the market. It is only one, a sustained release one that has been modified to release the drug over an extended period, maybe 12 hours or 24 hours, so that repeated administration will not be an issue. That is all that I'm trying to say. Compared to amlodipine, intrinsically, the drug is a long-acting agent and it can cover you for a whole day without you repeating. So that will be favored.
Okay. Please, thank you.
Welcome.
Hello, sir.
Any other questions? Hello?
Yes, sir. Sir, please, I just want to ask, why did they decide to choose only nimodipine for the aneurysm issue?
So it is the only drug among the class that preferably block the calcium channels of the blood vessels in the brain where this problem is occurring. You get it?
Yes, please.
All right.
Thank you.
Right. So it's just like the alpha 1 blockers, where some of them will block the vessels in the genitourinary system. So those ones like tamsulosin are used in BPH, not actually in hypertension. So some of the drugs, they prefer acting specifically at certain areas of the body. And we also take advantage of that and use them as such. Any other question? All right.
Sir,
Beta blockers. Yeah, hello.
yeah. And with the side effects of calcium channel blockers, are they also dose related, or with the even the lower doses you can't experience these side effects as in
Yeah, you
headache?
can. You can. Low doses you can, but of course, as you increase the dose, you predispose the person to side effect. So it doesn't matter. Even just 5 milligram amlodipine, you can still get your pedal swelling, especially when you do other things like too much standing or sitting in addition to these events. It can happen. But as you increase the dose, of course, the side effects also increase.
Okay. Thank you very much.
So beta
Hello, Doc.
blockers. Yeah, hello.
That side well. Like you were saying, and if Philippine has 1% effect on the heart, and like I didn't really get that part well.
Yeah. So as you can see, even with the non-dihydropyridines, they are saying that they have high effect on the heart muscles. And within those that we are saying, oh, they don't have much effect on the heart, within them, if you are to compare nifedipine and amlodipine, the two agents that are very common in Ghana, you realize that amlodipine has almost negligible effect on the heart, whilst nifedipine is going to give you around approximately 1% of their effect on the heart, with 99% effect on the blood vessels. So the issue here is that problems like heart failure with hypertension. Normally in heart failure, those days we say, hey, don't try calcium channel blockers at all. Because if you do, now the heart is failing. We even need calcium to increase contractility and you are blocking it. Nowadays, evidence has it that in heart failure with preserved ejection fraction, the ejection fraction is not the range. You are still able to pump. Though there is heart failure, you are still able to pump some respectable amount. You can use calcium channel blockers in such situations. But the thing is that still it is more prudent for you to use an agent that doesn't inhibit calcium channels on the heart as compared to you using agent that will have some level of inhibition on the heart. So between the two, heart failure with ejection fraction preserved, you would rather prefer amlodipine with almost negligible effect on the heart compared to using nifedipine with some effect on the heart. Are you okay?
Yes, please.
Right.
Hello, sir.
Thank you very much.
Yes, sir.
Hello, sir. Yes,
Yes, sir.
please. For the side effects, you mentioned that tachycardia is a side effect of using calcium channel blockers.
Yeah.
Yes, but you also mentioned that calcium is able to increase contractility. I wanted to ask how tachycardia is a side effect of calcium
Okay.
channels.
So tachycardia is an autonomic response. That is sympathetic effect. Tachycardia is heart rate. Contractility is about force of contraction.
Okay.
Though sympathetic effect can also increase contractility, but tachycardia is more of sympathetic activation, beta 1. You get it?
Yes, sir.
So when these agents, they cause that vasodilatation, there will be a sharp drop in the BP. So that reflex reaction will come in. Your body doesn't like surprises. So why is the BP going down so soon? Let's bring it back. So the baroreceptors will sense this drop in BP and then activate the sympathetic nervous system. That will cause beta 1 activation, so increase heart rate, increase palpitation. Are you okay?
Yes, please, sir. Very clear. Thank you.
All right. All right. So beta blockers. So beta blockers, preferably you are targeting the beta 1 adrenoceptor on the heart, because this is the receptor that when it is activated, you get increased heart rate, increased contractility. This will increase cardiac output and will automatically increase mean arterial pressure. So why not? Beta blockers, whether selective on beta 1 or not, we are blocking beta 1. So this agent can also be used in hypertension. Of course, they are used in hypertension, especially when it is after acute myocardial infarction. So these are normally first line. If you don't have any contraindications, beta 1 blockers, especially those who selectively block beta 1, are preferred as first line agent post MI. Why? Because after myocardial infarction, normally there is sympathetic activation. The heart muscles are not getting enough blood supply, and therefore your system reads that you don't have enough blood or whatever, or the heart is not pumping well to supply itself. So the sympathetic system is activated to force the heart to pump, because the heart muscles are not getting what they deserve. Meanwhile, you have some reduced lumen that is not allowing that, the supply. And therefore, when you increase the sympathetic nervous system and you cause tachycardia or palpitation, the muscles are even going to demand for more oxygen to be able to meet that tachycardia and palpitation, which per the pathophysiology you are not going to get. And this will worsen the situation. More cells are going to die. So what happens is that there is the need to blunt that sympathetic activation so as to prevent increased heart rate, increased palpitation, and therefore reduce myocardial oxygen demand. And therefore, beta blockers are favored, because when they block the beta 1 receptors, they reduce the sympathetic induced tachycardia and palpitation. By so doing, they reduce myocardial oxygen demand, which in this pathophysiology or pathology, you are not going to get the needed blood that you want. And if that happens, more cell death, MI worsens. And therefore, beta blockers, if you don't have any contraindications, they are considered as first line post MI. If you have contraindications like asthma, where you can use beta blockers, not even the beta 1 selectives are a sensible choice, because beta blockers at certain doses, they lose their selectivity and they can cause problems. In that case, you go in for calcium channel blockers to do this, because the calcium channel blockers can reduce contractility and the heart rate, especially the non-dihydropyridines. You remember phenylalkylamines and benzodiazepines, we said they have almost equal effect on the heart and the blood vessels, and therefore they will be chosen as second line to do this job. So beta blockers are used. Nowadays, we even use beta blockers in heart failure. Those days, the heart is failing and you are blocking beta 1 receptors to reduce its contractility. Are you not going to kill this patient? No. From evidence, nowadays, beta blockers are indicated in heart failure, but only when the patient is stable, not in the acute situations where there is dyspnea and what have you. No. After the patient is stable and you don't have acute exacerbations, beta blockers are chosen as first line. Why? Because they are able to block the beta 1 mediated renin release from the juxta glomerular apparatus. If this is triggered through beta 1 stimulation on the juxta glomerular apparatus, RAS is going to be activated. We don't want to see RAS in heart failure. Congestive heart failure, we don't want to see RAS, because RAS is the main cause of the numerous problems in heart failure. Left ventricular hypertrophy, aldosterone input of fluid overload, and what have you, increase preload and afterload. No. So if an agent can inhibit beta-1 mediated renin release, which is the first step normally in RAS activation, then the drug is favored in heart failure. And of course, there are so many evidence available to back this. 3 main agents are indicated when it comes to heart failure, beta-1. So those that are beta-1 selective, bisoprolol, metoprolol, and carvedilol that has an additional alpha-1 effect. So that one also helps to reduce afterload. You block alpha-1 receptors, you decrease peripheral resistance, and you are decreasing afterload. In heart failure, you want both decrease preload and decrease afterload. If you are choosing, in general, beta blockers for any indication, say hypertension, you need to consider certain parameters. For example, you need to consider how selective they are towards beta-1 receptors. And even if they have this property called intrinsic sympathomimetic activity, there are some beta blockers that fine, they fight against the sympathetic system. But in their action, when the parameters are going way too low, when the sympathetic parameters are failing, you are getting bradycardia as an example upon using beta blockers. Some of them, those with intrinsic sympathomimetic property, can reverse the decreased bradycardia and then give you an improved sympathetic effect. And therefore, we say that though they are beta blockers, they are enemies of the sympathetic system. Some of them do have intrinsic sympathomimetic properties, and in all, they cause less bradycardia as compared to those agents who do not have this property. And therefore, if you fear that a certain beta blocker will give you bradycardia, then when you are selecting, give preference to those with intrinsic sympathomimetic properties. I'll give examples later as we go. I have a whole slide for the different classifications. Examples of some beta-1 selectives are atenolol, bisoprolol, metoprolol.
Hello, sir.
Yeah, hello.
Sir, please, you're giving us a lot of information now, and it's going fast. Please,
Okay.
can you slow or give us like 5 minutes break?
Yeah.
It's like
You need break time.
Like 5 minutes, please.
Class captain. Then why not finish our normal up to 12, and if let's say we want to do more, then we go for break for like 5 minutes. How about that? Or class captain.
Like info overload, we beg.
Okay, you let me speak with your class captain. Class captain. My class captain, where are you?
Please, I'm here.
Okay. So your members are saying that we should go for break for 5 minutes and then come back. Is that okay?
I was thinking
Okay,
we'll still finish, but if they want the break, then we can do the 5-minute break.
So let's return at 11:15.
Okay, that's
because today we need to finish hypertension.
yeah.
I'm doing this detailed presentation because of the possibility of you meeting these drugs elsewhere. If not, if it's only, you see, I'm mentioning heart failure, MI, and those things because you are going to meet these drugs when you are doing these topics. So that you wouldn't have much problems. So you 5 minutes. That's what this topic will finish today. We have about 20 or so slides. After the class.
Sir.
Yeah, hello. Okay. Hello.
So please, when we come back, can you please go over it again?
Sure. I'll repeat this slide. Abi, is this slide that you were talking about?
Yes.
So we'll start from here, 57. After the classes, the rest are just straightforward. It's the classes that are packed. So you don't worry, you'll be fine. Okay, so 11:15, we'll be back 11:15.
Doc, it is 11:15. I think we can continue.
Hello? Hello?
Hi.
Hi.
Can we start? I added additional 5 minutes, so can we start?
Yes, please.
All right. So we are talking about beta blockers. As I said, yes, the topic is hypertension, but you are going to meet these same drugs when it comes to other cardiovascular conditions. So I'm trying to add all those things so that when you get there, then it will be a bit easy for you. So how do they work in terms of hypertension and the other cardiovascular problems? We are saying that the main effect is their blockade when it comes to the beta 1 adrenergic receptors found on the heart. When they do this, two critical effects happens. They slow down heart rate plus decreasing cardiac contractility. Remember when we did the hydraulic equation, we said cardiac output is a function of heart rate and contractility. So any agent that decreases the two automatically decrease cardiac output, which is also directly proportional to mean arterial pressure, and therefore BP drops. So that is how they work. But we are saying that these agents, for example, are very good when it comes to situations like post-acute myocardial infarction. Myocardial infarction, you have reduced blood supply to the myocardial cells, and therefore they die because it is blood that is going to supply oxygen and other needed nutrients. So for whatever reason, if you are not getting adequate blood supply, it means oxygen and the nutrients are not going, and the cardiac cells will die. Why is it chosen as first line? Should, in case you don't have any contraindications, after myocardial infarction, acute, beta blockers are normally first line. Why? Because right after the myocardial infarction, you are not getting enough blood supply. You are not getting, and the cells are dying. So your body will try to counter this and solve it. One of the means is to increase sympathetic activation. The body thinks that if it tries to increase contractility and heart rate, that will increase cardiac output. And increasing cardiac output means every organ, including the cells of the heart itself, will get adequate blood supply. Meanwhile, when the supply gets to the blood vessels supplying the heart muscles, there is blockade. So it means there's going to be sympathetic activation that will increase contractility and heart rate. Increasing contractility and heart rate also demands more oxygen. And in this case, you are not getting oxygen. So which means that the cells are even going to die more. And therefore, it is important for you to attenuate after myocardial infarction sympathetic activation, especially sympathetic effect on the heart. That is increasing heart rate and contractility. That comes after acute MI. And beta blockers with especially beta 1 selectivity, of course, will be the best. So they are chosen as first line when after acute myocardial infarction, you want to prevent sympathetic activation that will worsen the cell death. And I said that should, in case you have contraindications to beta 1 agent, then the second in command will be the calcium channel blockers, preferably those who have effect on the heart. So that is the non-dihydropyridines, phenylalkylamines, and the benzodiazepine, so diltiazem and verapamil. This agent will help decrease contractility and to some extent heart rate with different mechanism, not beta 1, by blocking calcium channels within the heart muscles. So they are chosen as second line to do this effect. Of course, they will not worsen asthmatic attack. Beta blockers, as you know, even with those that have beta 1 selectivity, they don't have beta 1 specificity. Selectivity is different from specificity. And with drugs, if you think that they are selective and you are going to use them anyhow, at certain doses, they may lose their selectivity, and what you don't even expect them to do, they may do. So in asthmatics, for example, it's still not advisable to use the so-called beta-1 selectives. And we are saying that in heart failure, previously, of course, you would think that a heart is failing and you want to minimize contractility. That's not sensible. You even want to improve contractility so that you don't let the heart fail. But during heart failure, especially after acute exacerbations, if you are not lucky, there will also be sympathetic activation as a reflex response to improve cardiac output. And this will put a huge burden on the heart, a failing heart, and you are forcing it to work. So after acute heart failure, you can also use beta blockers to attenuate the sympathetic response that normally happens. Again, it can also inhibit the renin release through beta-1 activation. That will activate the RAS system. And you know that in heart failure, we don't want to hear about the RAS system at all because almost all the numerous problems, the hypertrophies, the fluid issues, increasing preload and afterload, mostly is about RAS. So these agents with their beta-1 blockade, if it can decrease renin release and prevent RAS activation, why not? Just that during acute exacerbations, you don't do it. After the patient is stable, then you use it. In heart failure, 3 main agents are currently indicated: bisoprolol, metoprolol, and carvedilol. And I'm saying that carvedilol, apart from the beta-1 effect, it also has an alpha-1 effect. So alpha-1 effect means that it blocks the alpha-1 receptors on the vascular smooth muscles. This will prevent vasoconstriction, it will cause vasodilatation, decreasing peripheral resistance. In heart failure, you see that it will decrease afterload, and that will help in heart failure. And therefore, these agents are indicated. Then again, I said, if you want to choose any beta blocker, you should be doing some thinking. You should consider certain parameters. One of those parameters is this agent beta-1 selective? Of course, as in heart failure and MI, you'd want to choose an agent that is beta-1 selective so that you don't affect beta-2 and other things to cause so many side effects. One other important consideration is the agent having an intrinsic sympathomimetic activity? Why? Because beta blockers, as I said, they are enemies to the sympathetic system. But there are certain types of beta blockers that when they are antagonizing the sympathetic system and things are going bad, for example, you're having excessive bradycardia during the use of beta blockers, there are some that can help reverse the extensive bradycardia. So they cause less bradycardia, though they are enemies to the sympathetic system. And that phenomenon is that they are said to have an intrinsic sympathomimetic activity. This agent causes less bradycardia. So if you have any problem with this issue, beta blockers induce bradycardia, then you can choose an agent that has an intrinsic sympathomimetic property. Other considerations include their lipid solubility. Those that are more lipid soluble easily crosses the BBB and cause CNS side effects like sleep disturbance, nightmares, tiredness, and what have you. So all those things you may have to consider. So these are the agents. As I said, carvedilol has additional alpha-1 blockade. Labetalol is another beta blocker with some alpha-1 blockade as well. And all these will help improve BP properties and their good properties, the reason why they are employed in other cardiovascular issues. Are you okay? Are you okay?
Yes, sir.
Okay. So side effects, notably, of course, as for the sympathetic antagonism, you know already. But beta blockers are also known to alter glucose metabolism. With their beta-1 blockade, with their beta 1 blockade, they can also mask hypoglycemic signs and symptoms. So the autonomic signs and symptoms during hypoglycemia. During hypoglycemia, your plasma glucose is low. Your body tries to correct the hypoglycemia. So the so-called counter-regulatory hormones, they do the opposite of what insulin would do. These agents are released to come in and help increase the plasma glucose. Insulin reduces plasma glucose. The counter-regulatory hormones during hypoglycemia will be released or will be activated to come and increase the plasma glucose. These include glucagon that converts stored glycogen in the liver to glucose. So you are getting glucose from your stored glycogen. Cortisol that can help improve the production of glucose from non-carbohydrate sources in the liver, gluconeogenesis. Conversion of glycogen to glucose is glycogenolysis. You are only breaking down glycogen. But production of glucose from non-carbohydrate sources is gluconeogenesis. Cortisol, growth hormone, and adrenaline, these are all parts of the counter-regulatory hormones, can do that. In addition to adrenaline causing gluconeogenesis, the autonomic signs and symptoms of hypoglycemia that will make you aware that you are going hypo will be done by adrenaline, which is part of the sympathetic nervous system. One of the autonomic signs and symptoms will be tachycardia and palpitation during hypoglycemia. If somebody is on beta blockers, adrenaline will utilize beta 1 receptors on the heart to give you this tachycardia and palpitation. But here is the case: if somebody is on beta blockers, those receptors would have been blocked, and therefore the person will be having hypoglycemia, but the autonomic signs and symptoms, for example, tachycardia and palpitation, will not be experienced. That could be dangerous. To somebody, hungry comes in when normally the person thinks that he's having tachycardia, palpitations, and headache and those things. So if those things are not recognized by the patient, there is no hypoglycemia. The person will be there, and before you realize, he's off coma. So that is not a good thing. They can mask those autonomic signs and symptoms of hypoglycemia. And they alter glucose metabolism too. How do they do it? Beta blockers can cause both hypoglycemia and hyperglycemia. Clinically not significant though, but it's still something that occurs. How do they cause hypoglycemia? They can cause the inhibition of hepatic glucose production and glucagon release. Beta blockers can block glucagon release, which means you are not going to break down your stored glycogen to glucose because glucagon has been inhibited. Then gluconeogenesis too will be inhibited. In this case, you are getting hypoglycemia. On the other hand, they can also cause hyperglycemia. One of the mechanisms by which insulin is released is through beta 1 activation on the beta cells. So if you take a beta blocker and it blocks this beta 1, then of course you are going to have inhibition of insulin release. If insulin is not released, glucose stays in the plasma, and that is hyperglycemia. So they can do both hypo and hyper through these two different mechanisms. But clinically, this may not warrant that you stop taking beta blockers. That hyperglycemia or hypoglycemia may not cause for a total contraindication, but it's something that can happen. Another problem with beta blockers is patient compliance, because, for example, those that will cross the BBB because they are fat soluble can give CNS issues like depression, fatigue, and key to men and boys, sexual dysfunction, which is very dangerous to us because this is dear to our heart. So this problem, you put somebody who is sexually active on high dose beta blockers, don't be surprised the person will come back with crisis, because he will realize that the beta blockers are not helping him. He's not performing anymore, and the wife is always insulting him. So he will stop taking the drug and perform. By so doing, the BP will rise, and it may result in crisis. And therefore, when individuals are on beta blockers, because of the numerous side effects, especially to men, sexual dysfunction, patient education is very, very important. So this is to show some classifications based on when these drugs were discovered. So you have non-selectives and we have beta-1 selectives. So for beta-1 selectives, all these members and these members are beta-1 selectives. And we are talking about beta-1 selectivity. All those here, atenolol, bisoprolol, esmolol, metoprolol, acebutolol, and betaxolol, celiprolol, nebivolol. These are all beta-1 selectives. Those in this group are non-selective as well as those in this group. So carvedilol, labetalol, as I said, they have both beta-1 and alpha-1 effect. Catiolol, then bucindolol, these beta-1, beta-2 effects. If you come here, same. These are typically beta-1 and beta-2 agents. But according to generations, we have those that came first generation, second generation, and even third generation. So remember, the classification, we have two. If you want to go by generations, fine. If you want to go by beta-1 selectivity, fine. But always remember that being a beta-1 selective does not mean you are beta-1 specific. And for that matter, if you dare give the agent in situations where blocking other receptors other than beta-1 can pose problems, then they are not specific only to beta-1, they can still cause problems. So in asthmatic, it's not very wise to think that you are giving a beta-1 agent. And so the agent wouldn't have any effect whatsoever on the beta-2. It can happen, though the drug is a selective beta-1 agent. Any question? So these are the types. So if you want to know examples, those with intrinsic sympathomimetic activity and therefore they cause less bradycardia, you'll be looking at law can be used 1 daily, bisoprolol 1 daily, and the rest. Those with beta-1 and alpha-1, labetalol and carvedilol, they are very common. This one used as injectables in hypertensive crisis. Carvedilol very popular in heart failure and hypertension. Then you have beta-1 selectives. You have so many examples. So note again, I'm repeating, beta-1 selectives are not cardiospecific. They are not beta-1 specific. And they may lose their selectivity, especially at high doses. So an agent like atenolol, maybe at 50 milligram or 25 milligram, may preferably block the beta-1 receptor. But if you are not lucky at 100 milligram, it may lose this selectivity and block beta-2 as well. Imagine using 100 milligram in an asthmatic patient because you think that it doesn't have beta-2 effect. It is cardio-selective. Before you realize, then the person is having an asthmatic attack. So these are examples of some beta blockers and their half-lives. You can see a smaller that can be used during surgical conditions, hyperthyroidism, or maybe thyroid storms can be used to control. It has an interestingly short half-life, not even up to 10 minutes. So it wears off very quick. The advantage is that if any drug will cause side effects, that is dangerous, and it has a shorter half-life. Because of the shorter half-life, the effect wears off very quick, and you may not even need an antidote to reverse. Those with longer half-lives, if you find yourself in trouble, then you are in real trouble because they are going to work and work for longer periods, and you may have to stay with the patient, manipulate and prevent losing the patient. Any question? Any question? We will finish very soon. Once we are done with the classes, we are good to go. Class captain, any question, any issues? Can I continue?
Yes, please, you can continue.
All right. So the alpha 1 blockers. So we have alpha 1 receptors on the blood vessels. Stimulate this receptor, you get vasoconstriction. You block it, you are getting vasodilatation. In hypertension, you don't want any vasoconstriction because that will increase total peripheral resistance, which is directly proportional to mean arterial pressure. So we would want to block this alpha 1 receptor and rather cause vasodilatation. And that is what these alpha 1 blockers, they do. So they are employed, but normally they are not first line. They are not first line at all because they have a lot of issues, especially the syncope that comes with first dose, as well as vasovagal syncope. This causes a lot of vasodilatations, and then you don't get enough blood moving to the brain, then faintness will occur. So because of this, it is not actually agent that you would want to use as first line. But in men, those who have issues like BPH, benign prostatic hyperplasia, some of the agents that belongs to this class are able to cause vasodilatation, preferably in the blood vessels in the genital urinary system. And they are therefore able to give us benefit when it comes to BPH. So you know of tamsulosin, a well-known agent that is used in BPH. So they are used there. So they can be used for those purposes. Of course, you may want to use them as add-on therapies in hypertension, not first-line agent. So maybe a resistant hypertension that you don't know what to do. You've tried all possibilities and you are not getting enough benefit. Then you can use, but note that they have several negatives. Even in the AHAT trial, they realized that this alpha 1 blocker, doxycycline, was causing a lot of cardiovascular events as compared to clothalidine, that is a thiazide-like. So they are not favored that much, but when it comes to benign prostatic hyperplasia, then they are very, very important there. Because of the first dose syncope and vasovagal syncope, you should be cautious during initiation. So it is better to take this drug normally at night when you're about to sleep. Syncope normally occurs when you take these drugs in a sitting position and you decide to stand up. So it will cause pooling of blood to the extremities, the lower extremities, reducing blood supply to the brain. And then, so you take your first doses normally at night without standing up. You sleep immediately after taking it. And with time, maybe you get used to the effect. It will not happen. If you take it whilst you are walking, standing, especially your first dose, this syncope may occur and then you may fall down. We don't want to see any head injury and stuff. So that is enough on alpha blockade. We also have direct vasodilators.
I have a question.
Okay.
The other slide. You said it's beneficial in hypertensive men with the BPH.
Yes, please.
Otherwise, they're not recommended for initial monotherapy.
Yes.
So it means that if the man has the BPH and the HPT, I can use it as first line. Is that it?
Maybe, but even with that one, with this current trend of monotherapy not being effective, you may still have to do an additional drug plus this. But
okay.
Hello.
Hello. Hello. Okay. Hypertension. Okay. All right. Okay. So can you see my slide? Hello.
Yes, please.
Okay. All right. Okay. So let's continue. All right. So the direct vasodilators. So these agents normally are popular when it comes to hypertensive crisis, especially the emergency times where you want to use vasodilators. But in some normal practice, like hypertension in pregnancy, they are also utilized. Agents like hydralazine and the rest. So the three main agents that we normally use, we have hydralazine, minoxidil, that is not nowadays popular, and then the nitrate. So among them, hydralazine is the main guy. How does it work? So it works by inhibiting the release of calcium from the sarcoplasmic reticulum. Remember, for contractions to occur, you will need calcium. For contractions to occur, you would need calcium. And then calcium, it doesn't matter where it comes from, whether it is coming from the outside of the cell or inside, it is still calcium. And therefore, we wouldn't wait for calcium to release from this organelle within the cell to come and cause contractions and worsen BP. So all that we are going to do is we give hydralazine, it inhibits calcium that is going to be released from the sarcoplasmic reticulum. No contraction occurs, the smooth muscles of the blood vessel relaxes. Then we get vasodilatation. Remember, vasodilatation increases the diameter of the blood vessel. This decreases total peripheral resistance, which is directly proportional to mean arterial pressure. So when total peripheral resistance decreases, it means mean arterial pressure too will decrease. But there are problems with hydralazine and, of course, all vasodilators. One common thing about vasodilators is they cause a very sharp drop in BP because of very sharp drop in total peripheral resistance. So they can cause this syncope issue. They can cause edema, that is peripheral edema, because you get blood that will pool within the peripheral area. So the blood vessels in the periphery will hold onto blood and that can cause edema. But with hydralazine, it can also cause systemic lupus erythematosus. There is an autoimmune reaction, especially when you give high doses for longer periods. So it is both dose related and duration, and even gender. So female gender is a high risk factor for systemic lupus erythematosus caused by hydralazine. Those who are slow acetylators, to metabolize this drug and makes it inactive, you do acetylation. Some individuals are slow acetylators and they can also get accumulation and suffer from systemic lupus erythematosus. Family history of any autoimmune disease could also pose as a risk factor. Minoxidil. How does minoxidil cause vasodilatation? In vasodilatation, you don't care about the mechanism. All that you need is the muscle should relax. The smooth muscle of the blood vessel should relax. Whatever mechanism that will lead to that, we don't care. Once it relaxes, we get vasodilatation. Hydralazine did so by antagonizing calcium release. Minoxidil will do that by what? Causing the ATP-sensitive potassium channel to open. When it opens, potassium will leave the cell. This will make the cell hyperpolarized, very stable. There will be no activity in the cell and there will be no contraction at all. So minoxidil will approach it by opening the ATP-sensitive potassium channel. Potassium leaves because you have more potassium within the cell than outside the cell. So the moment the potassium channel opens through simple diffusion, the potassium will move from the region of high concentration, which is within the cell, to outside the cell. By so doing, you create increased negativity in the cell. That is hyperpolarization. The cell becomes so stable, no activity, no contractions, and you will get vasodilatation. One interesting thing is that this vasodilatation, when it comes to minoxidil, can actually improve blood supply to hair cells and hair follicles. And for that matter, you can guess. Nowadays, you see a lot of guys wearing beard. They'll go and buy some creams or sprays that contains minoxidil as the active ingredient. What is it going to do? Through its vasodilatation effect, it improves blood supply to hair cells and hair follicle, and for that matter, they get improved hair growth. That is what they do nowadays. Hardly would you see minoxidil, especially in Ghana, being used for hypertension. Of course, as I said, because these vasodilators will cause increased vasodilatation, they are likely going to cause a lot of problems. Edema, that is ankle swelling, syncope, and if you are using hydralazine, then you add those erythematosus. You see flashing and reflex tachycardia and palpitations, all these things may happen. So normally, they are not used as monotherapies because of these problems. So if you remember the counter effect, one of the reasons why you use drugs in combination, we said that one drug could be used to counter the side effect of another. So maybe you may use vasodilators plus another drug, for example, beta blockers, if you want to use vasodilators, so that the beta blockers can counter the reflex tachycardia and palpitation that the vasodilators will bring. When it comes to the edema, as an example, you can use diuretics in combination with the vasodilator to also counter the possible fluid retention that may occur. As I said, minoxidil is used nowadays as a cosmetic agent. So for men, because they want to grow their beard, it's beneficial. But for women, it becomes a negative effect. Hirsutism, women don't like facial hair and those things, so they frown over the use of minoxidil. Note that when it comes to hypertensive emergencies, hydralazine is very, very strong there, together with beta blockers like labetalol. Nitric oxide agents. For example, you use an agent like the nitrate. When you use the nitrate, let's see how they play their role in vasodilatation. So the nitrate will utilize the action of nitric oxide as a natural endothelial relaxing factor. What do they do? When you take the nitrate, then they will utilize certain structures in the body called thiol groups. Others will call it sulfhydral groups. When they interact with sulfhydral groups, nitric oxide is released. Nitric oxide will pass through so many signal transductions by activating guanylyl cyclase that will lead to the activation of cyclic GMP. And finally, cyclic GMP will antagonize calcium levels that will lead to vasodilatation. So nitrate will interact with thiols, also known as sulfhydral groups. When this happens, you get the release of nitric oxide, or it is produced. This nitric oxide, in turn, will activate or increase the levels of cyclic guanylyl monophosphate, cyclic GMP. The end result is that you activate several other proteins that will antagonize levels of calcium in the cell. Once you antagonize calcium, you are not going to get contraction. You are rather going to get vasodilatation. And that is the end result. Once you get vasodilatation, the blood vessel has opened, and therefore you get reduced resistance. Reduced resistance will give you what? Reduced mean arterial pressure. These agents normally will not be used a lot in hypertensive crisis, but rather in MI and angina. So when you have acute angina or acute MI, you want to increase the diameter of the blood vessel so that you can have some amount passing around the point of blockade. Then nitrate will be a good agent. Note that the nitrate, we have the injectables, we have the sublinguals, you have inhalation. When you are doing myocardial infarction, you'll be taking through all the various formulations, the dosage forms of nitrate, sublingual, buccal tablets, oral tablets, injectables, inhalationals. Normally, the sublinguals, injectables, inhalationals are used for acute situations, whilst the conventional tablets are used for chronic management of coronary artery diseases. If you are using the conventional tablets for longer periods, one main issue of concern is the so-called nitrate tolerance. Nitrate tolerance. You keep on using the drug. Remember, I mentioned that they will interact with sulfhydryl groups, aka thiol groups in the body. So all the time that you use this drug, you are interacting with this agent. With time, the thiol groups may get depleted. It means that if they get depleted and you take the drug again, you wouldn't have thiol groups for the drug to interact with to be able to produce this nitric oxide. What happens is that the response that you are looking for, the vasodilatation and the final response, won't happen. So thiol depletion is a problem, and that comes with continuous administration. So what is the intervention with this problem? What you do is every day you leave some fallow period. It's like the farmers agree what you were told. You do farming, it gets to a certain time, you have to what? Stop for the land to get replenishment, get back the lost nutrient. Same thing being applied here. When you give the drug, at least in 24 hours, you wait or you give a period of 8 hours, a minimum of 8 hours for the body to get back and then replenish, reproduce the thiols again, so that the next day when you take your nitrate again, there will be more thiol groups for the nitrate to interact with for it to produce your nitric oxide. So nitrate-free period is crucial when somebody is on chronic nitrate use. A minimum of 8 hours for the body to recapture the depleted nitrate thiol stores, so that when you take it the next day, there will be thiols for the drug to interact with for you to produce the nitric oxide for active effect. That is what you do. For this reason, oral regimen for nitrates is termed to be asymmetrical. What do I mean by asymmetrical dosing? Symmetrical dosing. For example, when you say BD, base in dye, symmetrical dosing means, for example, 8 a.m. and you repeat it at 8 p.m. That is symmetrical, balance, both morning and evening time. But when it comes to nitrate, because you want to get at least 8 hours nitrate-free period, you don't do symmetrical dosing. If you do symmetrical dosing, you may not get that 8 hours or enough time for the nitrate-free period. So we do what we call asymmetrical dosing. So you don't divide it equally. So for example, when you say isosobide dinitrate, let's say 250 microgram BD, that is what you see on the prescription. With this drug, you are not going to do it, say, 8 a.m., 8 p.m. You may do it, say, 8 a.m. and 4 p.m. or 5 p.m. because you want to leave more time where in the body you wouldn't have any nitrate in the body. Then the body will use that time to replenish the tire's bodies so that the next day when you take the drug, it will work. So the strategy with nitrate is to do asymmetrical dosing, not the normal symmetrical dosing with other drugs. Why? Because you want to acquire the nitrate-free period so that you avoid nitrate tolerance. Any question? Any question?
Doc, please, could you go over the example with the accessible dinitrate prescription?
So the accessible dinitrate, just as an example, or mononitrate. I'm saying that because you want to achieve the nitrate-free period, to avoid the drug not being able to work continuously. Because if you do that, you will always have nitrate in your body. And once you have nitrate, they will deplete your thyroid stores because they interact or they utilize your thyroid stores to be able to produce the endothelial relaxing factor, that is nitric oxide. So all the time, you make sure that you leave some fat for your thyroids. If they are produced, they will be stored. So that by the next day when you take another nitrate, thyroids to interact with the drug for activity to occur. And this is not supposed to be less than 8 hours within a 24-hour period. Your body rebuild the nitrate stores. So for normal, as in dosing, we call it symmetric. When we say TR in every 4 hours, BD we mean every 12 hours. But with nitrate, when we and there will be tolerance. So what you do is to do asymmetrical dosing. For example, instead of you doing 8 a.m., 8 p.m., you can do 8 a.m. or 7 a.m. and 4 or 5 p.m. so that you have enough time. So the drug will be cleared from the body, depending on its clearance, maybe 4 hours, 5 hours, from 4 p.m. to 8 p.m. or 9 p.m. Then there will be no drug in the body from 9 p.m. till the next morning, 7 a.m. or 8 a.m. that you take the drug. And the body will utilize that nitrate-free period to rebuild the thyroid stores that your nitrate used up during the daytime when you had taken your nitrate. By this, the drug will always give you a response. But if you do symmetrical dosing and it makes it possible for your body to have nitrate all the time, then your thyroids will be depleted all the time. You take the drug and it won't work. Are you okay?
Please take the timing again.
A minimum of 8 hours. So that's the strategy. So you are doing asymmetrical, something abnormal from the normal thing. You know, when we say BD, you know that it is 8 a.m. in the morning, for example, and 8 p.m. in the evening. So that is typical BD. So for example, in nitrate, to be able to get that minimum of 8 hours where you don't have any nitrate in the body, you are allowed to do asymmetrical dosing. So instead of 8 a.m., 8 p.m., you can do 8 a.m. and do the second dose at 5 p.m. So that, say, by 9, 10 p.m., per the clearance, the drug will be cleared from the body and you have this free period where you don't have nitrate in the body. So that the next day, your body will use that nitrate-free period to reproduce more thyroids. So that thyroids will be available in the next morning when you take the drug, for the drug to still give you activity. Are you okay? So this is just an example. Are you okay? Hello?
Yes.
Hello? All right. Okay. So yes, that is what they cause this vasodilatation, then you get improved effect. So in ischemia, coronary artery disease, you see a lot of nitrate being used. All right. Okay, so now we are done with all the pharmacologies. Let's now come to the therapeutics proper. Therapeutics proper. So, as I said, combination therapy rather than monotherapy is popular nowadays. Simply because normally subjects who have hypertension will present with BPs that is more than 20 systolic over 10 diastolic above their goal. So you remember the goals. You remember the goals that we stated, depending on age, depending on comorbidities. We stated some goals. Yes. So these are the targets, treatment targets. So normally you would expect that a normal adult with no renal, no diabetes, nothing, we expect that when we give you treatment, we are reducing it to below 140/90. Elderly above 55, for obvious reasons, vascular restrictions and atherosclerosis, you don't compare them to this. So you don't set this for them at a bit higher one. But most of the patients will present with more than 20 systolic and more than 10 diastolic above their goal. And in these situations, if you try and then you joke with monotherapy, you are never going to get to your goal. So because of these reasons, multiple therapies, either double, triple, or at times even quadruple therapies will be the case. And therefore, combination of antihypertensives are used. Remember the reasons why you do combinations: for improved efficacy, of course, to get to the target. At times, you use some of them to counter the side effect of others. And at times, due to the additional benefit, you just mentioned pleiotropic benefit, you use them in some compelling indications. Somebody with renal disease, with hypertension, you would want to give a nephroprotective agent that has antihypertensive activity. And again, you can even do a fixed dose combination. You can see at times amlodipine in the same one tablet with hydrochlorothiazide. In this case, if it's able to work, then it's better because you see you are taking one tablet 2-in-1 as compared to taking the two separate tablets. 2 tablets versus 1, it is easy to take that one. In most cases, it gives you better response and the cost is even lower as compared to you going to buy them individually. And compliance too is enhanced. And therefore, if you are using fixed dose combination therapies, that could serve as an advantage. But in combination therapies, please remember combinations like ACEs and ARBs. We are not saying that you can't use them. You can use them, but in heart failure, under specialist supervision. So please, you don't, in hypertension, just normal hypertension, you don't go and use ACEs and ARBs for total blockade. But in certain situations in heart failure, combination therapy of AC and ARBs may be warranted, but under strict supervision. Combination therapies with either ACEs and ARBs together with diuretics or calcium channel blockers are also backed by evidence. For example, the accomplished trial, it demonstrates that when you combine CCBs with AC inhibitors, they are very, very effective in hypertension. So there are so many evidence backing or reasons backing combination therapies over monotherapies. Again, monotherapies, you may have to even escalate the dose, and that will predispose the person to side effects. Why not give 2 different drugs with different mechanisms at lower doses so that you dodge or you escape the side effect of the 2, but the 2 together will give you combined effect, synergy. So combination therapy is very important. But at times you do all that you want to do and the patient BP will not respond, especially when the patient has done anything that he's supposed to do. He's buying the drugs, taking them. The drugs are classic, very potent, effective agents. And then the clinician too has done his work, appropriate doses and everything. You've given 1 drug, 2 drugs, 3 drugs, and still the BP is not responding. At this point, where the BP is not responding, minus all other inputs from the clinician and the patient, we say that we are having resistant hypertension. So resistant hypertension is when a true resistant hypertension, is when you have used 3 drugs. All parameters that will affect negatively the treatment is not there. Compliance is on point. Appropriate dose is on point. Everything is on point. Yet, the BP is not responding after using 3 drugs. If this happens, then you say that the patient is having resistant hypertension. At this point, a general practitioner shouldn't handle the case. This case should be referred to a cardio specialist, for him or her to do this treatment or management. And at this point, the strategy is to do aggressive BP control by using antihypertensive agents, though at their maximum tolerable doses. And this is patient specific. You may tolerate 5 milligram amlodipine, but can't tolerate 10 milligram. Somebody can tolerate 10 milligram, and 10 milligram will be that person's maximum tolerable dose. For me, 5 milligram amlodipine is my tolerable dose. I don't want to experience any side effect. Now, you could have certain factors that can make hypertension look like it is truly resistant, though it is not a true resistant case. So factors like if, for example, the doctor doesn't give appropriate doses, white coat effect, you see any person in white coat and then you get sympathetic activation, you don't start the drugs as you are supposed to start, you are doing poor adherence. If any of this is contributing to the BP not responding, then you say that you have pseudo-resistance. This is not a true resistance because there are clear factors that is sometimes the doing of the patient or the clinician that if you are able to do it proper, you wouldn't get resistant hypertension. So in this case, we say that you have resistant hypertension. But there are other factors that, of course, is not the doing of anybody. For example, other factors like, let's say the person is having obesity, you control, it won't take. The drugs, they are just not responding. In that case, then you say that the person is having what? True resistant hypertension. Of course, as I said, when this true resistant hypertension is confirmed, then the goal is to use aggressive approach. Specialist cardiologists will have to handle this case. In most cases, the true cause of resistant hypertension is plasma expansion. So it means that there is volume overload. So then you should be thinking about maybe additional hypertension. The first 3 agents that you may use, of course, all things being equal, may include a diuretic. So normally is a CCB plus a diuretic, then plus an ACI or an ARB. These are normally the 3 agents that you use. So the 4th agent, if it is diagnosed as resistant hypertension, because we are saying that plasma expansion is the most common cause. It could also be other causes, but the most common cause is plasma expansion. Then it means that only the first diuretic among the 3 is not able to do the job. And therefore, an additional diuretic would normally be considered. At times too, the diuretic may be there, but it may not be working. For example, when you use thiazides in renal subjects with estimated glomerular filtration rate less than 30, for thiazides and thiazide, apart from metolazone, all the others at this EGFR, they won't work. But metolazone will give you some effect. So here, normally we use Bendro. So Bendro may be there and the person is having EGFR below 30, and it means it won't work. So in that case, then you have to review the medicines and then change accordingly. But should in case you need to add a 3rd agent, then agents like spironolactone. Hello?
We can hear.
Okay. Should in case you need to add a 4th agent, since mostly it is plasma expansion, then you may consider the aldosterone antagonist spironolactone, which will antagonize aldosterone and also give you additional diuretic effect. In some situations, agents like methyl dopa may be given, agents like alpha blockers, maybe, but it depends. But the fourth agent, normally, in most cases, because of plasma expansion being the common pathophysiologic mechanism, you may want to add a diuretic as the fourth agent. And when it comes to that point, spironolactone should be considered. Remember the problems with aldosterone. Aldosterone has a whole lot of issues when it comes to hypertension and heart failure, and therefore spironolactone will be considered. If you have issues with gynecomastia and stuff, then you can switch to eplerenone. So that is the way forward. Then we have this phenomenon, clinical inertia. We will finish very soon. Clinical inertia. So clinical inertia is when patient and prescriber factors affect our treatment. It prevents us from getting our treatment goals. So our own doing, if it affects us, prevent us from getting our goals, then refer to it as clinical inertia. So examples include lack of treatment initiation. You've been diagnosed, confirmed, but the clinician is reluctant. He doesn't want to start. Or you don't want to start because your belief has it that you can't never have hypertension. Even if you accept and you do poor adherence, the doctors, they fail to modify or intensify the treatment upon every visit. They review, there is the need to change, modify the treatment, then they don't. Or they give inappropriate follow-ups or monitoring. All these can contribute to failure to achieve our treatment goals. And when this happens, we say that we are having clinical inertia. Now, the last point, hypertensive crisis. We said we have emergency and urgency. In both situations, the BP reading should be above 180 systolic and or 120 diastolic. If you have target organ damage, that is hypertensive emergency. If the BP is high up there without target organ damage, then you have the urgency type. So target organs that can suffer in hypertensive emergency could be the heart, where you could have coronary ischemia. You could even have stroke. You could have so many other events, eye problems, acute renal failure. So it is very important that in a hypertensive crisis, you distinguish between the urgency and the emergency type because they have different approach when it comes to the treatment. The emergency type will be utilizing IV antihypertensives, and there is some time within 3 hours where you have to reduce the BP by a total of 25%. The first hour, you do 10% reduction. Then the second to the third hour, you do the remaining 15% reduction. It's actually the mean arterial pressure, not the BP. You know the BP is different from mean arterial pressure. So in crisis, it is the mean arterial pressure which actually reflects tissue perfusion. It's what you are reducing, not just the BP. So if you don't have a monitor that can automatically give you the mean arterial pressure, then you have to utilize the BP readings, the systolic and the diastolic, then you calculate the mean arterial pressure. How do you calculate the mean arterial pressure from the BP readings? What is the relationship between systolic, diastolic, and mean arterial pressure? Class captain. Class captain. How do you calculate MAP from systolic and diastolic BP readings?
1/3 of
Anybody?
systolic plus 2/3 of diastolic.
Okay, so another person can also do diastolic plus pulse pressure over 3. So you do it, and your target is to reduce, if it's emergency, the first 1 hour, you reduce the mean arterial pressure by 10%, and the next 2 to 3 hours, you reduce it by the remaining 15 using IV antihypertensives. If it is the urgency type, then you use conventional oral preparations, oral antihypertensives. You reduce the BP by 25% over a day, that is 24 hours. So these are some of the common target organs that can damage, and the rate, the possibilities. So cerebral infarction, that is ischemic stroke, as high as 24.5%, congestive heart failure 12%, hypertensive encephalopathy 16.3%. So during all of these can happen, even up to this phenomenon called posterior reversible encephalopathy. So when this happens, the patient of headache, there could be altered mental status, visual disturbance, and even seizures. Hypertensive crisis can bring all of these. So when it is the urgency one, you are using conventional oral tablets. Within 24 hours, you reduce the BP by 25%. The MAP, not the BP. But when it is the emergency where you have clear evidence of target organ damage, that one you don't have time because you can't wait till 24 hours. If you do that, more organs will be damaging. So immediately, within the first hour, your target is to reduce the mean arterial pressure by 10%. Then the next 2 to 3 hours, you reduce it by the remaining 15%. Notable agents include IV labetalol, IV hydralazine. So, in conclusion, you realize that most guidelines will say that, oh, the normal BP, if you get 140 over 80, it's okay, or 140 over 90 is okay. But there is evidence from the strength trial that, remember, we even said that the cardiovascular risk almost always begins from 115 on 75. So even with 120 on 80 is still not the best. So don't be happy with your 140 on 90 because it is better, you get better response if you are able to what? Put it below 120 than below 140. So those who are able to target this, they have lower rate of fatal and non-fatal cardiovascular events and mortality from all possible causes than those who target around 140. So it is better to keep it tight and try to achieve this rather than this. But if the 120 is not achievable, at least get your 140. Any questions so far? If not, this brings us to the end of hypertension. I hope that at least I've been able to give some information that would help not only in hypertension, but the other cardiovascular conditions. Any question? Any questions so far?
Sir, please, I have a question.
Okay.
Can you please just explain briefly the statement you made about the Kabedi law, about it having alpha-1 effects, so it being effective in heart failure management?
Okay, so in heart failure, one of the problems is if the total peripheral resistance increases, then it means that the pressure within the blood vessels through which this failing heart must fight against to overcome and pump the blood through is increasing. The heart is failing. You want it to struggle before it's able to pump and generate enough pressure to overcome a very high pressure within the blood vessels. That is what we call increased afterload. So the resistance within the blood vessels against which this your failing heart must work against to overcome and be able to pump blood through. You don't want it to be high because your heart is weak. It's not able to generate enough force. So you don't want your heart to be struggling to overcome that afterload. So with your Carvedilol, it has the alpha-1 effect. Once you get alpha-1 effect antagonism, you are relaxing the blood vessels. This will decrease the pressure within the blood vessels. In heart failure terms, we say you are decreasing afterload. And therefore, for even this failing heart, the little pump that it's able to generate, the blood will easily push through. And that will not make your failing heart struggle. So in heart failure, yes, carvedilol is favored because it can decrease your afterload for you with the additional alpha-1 effect. Are you okay?
Yes, sir. Thank you.
Right, welcome. Any other question? Class captain, any information for us? If you don't have any question. Yeah, are there situations where IV and antihypertensive are used in agency? No. Agency, since you don't have any target organ damage, you are not in a rush to urgently, or quickly decrease the BP. So you have a luxury of 24 hours, and then you decrease it over. Once you get any hint of target organ damage, then it's no more urgency, it's emergency. Then that one you don't have time. So you quickly use agents that you can titrate. The IV injectables you can titrate and then manipulate to bring down the BP as stated. 10% first hour, 15% second to third hour. Yes, anything. Class captain.
No, please, no questions.
Hello, sir.
Okay.
Yeah.
Hello, sir.
Hello.
Hello, sir. Good afternoon.
Good afternoon.
Please, I've seen that in the hospital, when there's a hypertension agency, you realize that they sometimes add sedatives. Does it have any therapeutic effect in addition to the antihypertensive?
Sedatives as in which particular type?
Sometimes you see given diazepam.
So is it that maybe the patient is trying to have some seizures or whatever? Because you can have the press. This one. This phenomenon that comes with seizures. That is a possibility. So, or maybe the person becomes anxious, there is anxiety, and that can even activate the sympathetic system. So they are trying to calm the person down. That may be the indication for that additional sedatives. Either there is threatening seizures, or maybe they want to control possible anxiety that will worsen the BP through sympathetic activation. Either than that, for typical urgency, you focus on your antihypertensive orals and then you manage. So maybe the additional problems, maybe they check and then they see that the person is anxious because of fear of dying or whatever reason, and therefore they will have to institute. So it depends on what is happening. I don't think it's a protocol that for every hypertensive urgency you should add a sedative, but patients is all about individualization and normally what happens during the time of management. So I'm not surprised though, but it's a possibility. But typical for urgency management, it is about the antihypertensives. But certain other parameters may call for the use of other agents like the sedatives that you are saying. Any other question?
Thank you.
Hello. Yeah, good afternoon.
Yes, sir.
Yeah, so with regards to hypertensive emergencies, if, for instance, a patient comes to the emergency room with a hypertensive emergency, and after initiating carbitalol or maybe hydralazine, the BP still spikes up occasionally, what's the next course of action?
Oh, there are several other agents. Just that in Ghana, the options normally are not that much. We even have nicardipine, which is also a very good agent, a calcium channel blocker that you can use. It comes in an IV form. So you can also use that one. So it's all about you trying to lower the thing down. But of course, you may have to look out for underlying causes too. Because, for example, if the BP is high and then you are managing and it's not going down, meanwhile, you are loading some fluids at the same time. You see the thing? So at times, there may be some underlying cause that you may have to abort. So this is a typical example. IV fluids running normal saline, for example, and the person is having crisis. then you forget that your IVs are running and you are increasing plasma volume and you are only giving your drugs, it won't work. So in that case, if your treatment is not responding after hitting, say, maximum doses, then you may have to look out for underlying causes. If there is any stress that is happening, any trigger factor, you may have to look out for those factors, whether drug or non-drug related factors, and try to abort. Are we okay? And try to do combination. So these situations are normally handled in the ICU or maybe another third class ward. You don't normally do hypertensive emergency management in normal wards. Normally, wards that can control at least 2 organ systems or 3 organ systems. So typical of the emergency unit and ICU, this is where you are supposed to handle. Well, they have better knowledge in managing such situations than the normal ward. Are you okay?
Yes, please. Thank you very much.
Right. Welcome. Any other question?
So please, are we going to look at hypertension in pregnancy as a separate topic on its own?
In fact, I have not actually, that's not part of it, but I think you will have to include that. So you look at that, but that would be a brief thing because it's not like detail something that is all about eclampsia and the choice of drugs that you do. It's the same crisis management, just that the drugs should be indicated in pregnancy and maybe the additional protocols that you do as part of the management, maybe max sulfate protocol to abort seizures and those things. If not, it's the same way of management. You just need to know that the drugs will be indicated in pregnancy. So labetalol, for example, can be used. And then maybe the max sulfate protocol. And the protocol nowadays is institution specific. They have different strategies of giving the max sulfate protocol and the other non-pharmacological. So it's not a huge topic. Of course, it is one of those examples of hypertensive emergencies. So we can handle it within maybe 5 minutes or so.
Okay.
Any other thing? If not, class captain, any announcement? Hello?
No, thank you very much, Doc.
All right, so next week.
So next week.
All the best. So read through, and then get yourself ready for the other cardiovascular topics. All right. Nice day.
You too.
Nice day. Bye.
Bye.
Next week, what are we doing? Sorry.
Yeah, next week, in fact, it's even 50-50. I may not be even around. So you will decide in the course of the week and then inform your class captain for him to tell you.
Yes, please. Thank you.
It's most likely that I may not be around on next week, Saturday. If that happens, then you have to push it to Sunday. Sunday, like from 3 p.m. to maybe 5-6 p.m. But I will send the topic to your class captain.
Yes, please. Thank you.
All right. Welcome.